Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Lee Yin, who's a pioneer in outpatient immunotherapy, CAR T therapy. She's chair of the Cellular Therapeutic Cross-Disciplinary Group, professor of medicine in the Division of Hematology at the Mayo Clinic in Rochester. And we are really delighted to have her here to share her vision about outpatient CAR T and immunotherapy, which she's a go-to person for people from across the country. Welcome, Yi.
Thank you so much for having me, Dr. Vij. It's a pleasure to be here.
So Yi, so first of all, why an outpatient immunotherapy program? Why should we go to outpatient? Why not keep doing it inpatient?
That is an excellent question that many treatment centers across the country are looking at. It's certainly not unique at Mayo Clinic. And I'll say the concept for outpatient management for patients with cancer getting treatment is also not new. It's not something we just started, for example, since we have FDA approved CAR T treatment and so on. It's something that's been developed over decades with what we had with stem cell transplant for a number of hematologic malignancies, managing patients who are getting chemotherapy who may have low blood counts, and do we have to keep them in the hospital over time? So there's this cumulative decades of experience where we've learned how to do it safely. One, patients are not as comfortable sleeping in hospital beds, at night. And so if they can stay out of the hospital for longer, they may have a better experience. And we see that in the patient surveys of their experience coming back. And if we were to look at potential risks for hospital-acquired complications, the longer you stay in hospital, there may be bacteria that are more resistant to antibiotic that, lives out in the hospital. So you might pick up those type of more resistant type of infections, and that risk could go down the more we can safely keep patients out of the hospital. And for, all of the treatment centers, we have limited hospital bed. We have limited number of nurses and physician clinical staff. And so if we're able to manage patients more outpatient, then with the same amount of resources, we can provide more care for more patients. So I think the key is that we need to show the process and infrastructure we set up that we can do it safely. It's a positive experience for patients, and it supports the growing need of the patient volume. So certainly, from my perspective, I'm most familiar with CAR T cell therapy program and so on, but I have the advantage of already having a practice that has a lot of experience with outpatient management, but building in how do we do that with novel immunotherapies that are now in the practice.
So also, I guess one of the impetus, especially in CAR T, is the reimbursement structure. Hospitals too, to be able to offer these to patients, need to make it economical. And I understand that outpatient reimbursement allows them to expand these programs and make them available to more patients.
The financial aspect certainly is a very complicated discussion. And I think this is something that there needs to be ongoing advocacy for where the practice is already innovating and how we can advance our ability to care for a patient. And the payment system, for example, with the CMS and so on, needs to also catch up. And so traditionally, yes, when we think about, for example, how the government has been paying for care, where they consider if a patient needs to be hospitalized within, in the US, very common 72-hour window, if they need to be rehospitalized, then it's very likely related to potentially complication from prior treatment and so on. So there's a system where if a patient is hospitalized within 72 hours of, let's say, a very expensive treatment like CAR T, then the payment may only be related to that hospitalization. The risk is that the very expensive treatment that was given outpatient or was prior hospitalization may not be adequately covered. Now, with CAR T, it can be a little bit complicated because there is, when a new CAR T comes out, there is what's called an NTAP a coverage where they tried to say it's a very new technology, this is new, that's coming to practice. And so there's a little bit of a supplemental payment to try to cover for that. And for some product, unfortunately, that's given with inpatient. So there's a little bit of a mixed balance, but the NTAP is only limited for a period of time, and it expires essentially when that product been in practice for a while. So I think the general idea is, in terms of when you look at the overall cost of providing care and then the payment, the more that we recognize the value that we're covering for the care outpatient, and that the payment is built to account for that, then that also, yes, it contributes to having a sustainable financial program, not only the clinical aspects and the quality of life aspect of the outpatient care.
So it seems like it could potentially be a win-win both for patients and
And for the treatment centers, absolutely.
centers.
Absolutely.
So is outpatient immunotherapy CAR-T for everybody?
I do get asked this a lot, and I will say, I can share how we do things at Mayo Clinic. And I think this is a very complicated question. And I think it can be the right thing, but there are many pieces that needs to come together. So at Mayo Clinic right now, we'll say, yes, it's the right thing for most patients because of how we have set up the infrastructure. When I think about outpatient care, there's many pieces that needs to come together, right? One is the treatment center. When they say outpatient, what do they mean? What part of the care is set up outpatient? How nimble is that outpatient clinic or facility that are able to see patients, let's say on short notice? What is the coverage like on nighttime, holidays, weekend? And how accessible is that escalation of care? Let's say a patient at some point, because of certain side effects where they do need inpatient care, how readily available is that? So once we understand, and every institution can be different, in how they set that up, once they understand that, then they may say, okay, for certain CAR-T treatment where we understand in general the likelihood that these side effects might come on or in this window, does that fit well with that infrastructure for the outpatient? And then for the individual patients, there needs to be a very careful, educated discussion in terms of if you're getting this care outpatient, right? One, where would you be staying? Is there reasonable housing available? Is there transportation available? Do you have a caregiver that can be with you in the outpatient settings? And these are all different pieces to consider, the patient's ability to follow through with the outpatient monitoring, the support system, their disease burden coming into the treatment, the type of treatments, and the timelines of the side effect in the infrastructure. At Mayo Clinic, because we've done it for a long time, we're very confident that the patient we're assessing, we're able to provide outpatient care, but that's because we look at all of these different components. And I do know there are other centers who may say, yeah, for this type of patients or, patient with these risks, because of our infrastructure setup, we feel more comfortable that these patients with these profiles to manage inpatient, but these other patients, we're very confident we can manage outpatient. And I think all of these models are okay as long as it's set up in a safe manner. And as we have evolving technologies and the treatments evolve, the management evolve, we may all be able to do more of that.
So these patients do generally at Mayo Clinic require a dedicated caregiver. Do you mandate that?
Certainly for CAR-T treatment, that is something that we do ask. When they're not in a hospital, they need to have a caregiver with them. Now, it doesn't have to be the same person for the entire time. Currently, the FDA requirements, for example, for an approved CAR-T, they need to stay near the treatment center for a month after infusion. That can be quite a long time. If they happen to have the same caregiver for the duration, that's great, but we also recognize we don't want that to be a limiting factor. So if they have family members, very close friend that could take rotations for different weeks of the month, that's fine by us. We just go through all the appropriate education with that caregiver and the patient.
So I know you said that it all depends on the modality and what the infrastructure you have as to your choice of who you would give it outpatient. At Mayo Clinic, do you have any cutoffs for performance status, age, any of that in terms of deciding who to give, say, a CAR-T outpatient to?
So for our practice, when we first evaluate the patient for eligibility to go through CAR-T treatment, the intent is to treat everybody outpatient. Generally they're doing that evaluation in an outpatient setting. They're generally feeling well. We're assessing their organ functions, their other potential medical conditions. Are they fit enough to go through treatment? The intent is always to do outpatient, and we cover what are the needs and considerations for that. But CAR-T treatment is unique or different from, let's say, stem cell transplant or even some of the chemotherapy, in that the patient goes through different phases of the treatment, right? The first phase is evaluation for general eligibility. Then we collect their white blood cells to make the CAR-T. And the making of the CAR-T process, it varies between product, but it can generally vary from a few weeks to more than a month. So things may be happening with their cancer in the interim. We'll try to keep those cancer under control with other types of treatment, but that may not always be under our control. And so they could have changes in their medical condition such that by the time the CAR-T cells are ready, they may not be doing as well, right? So we always repeat the assessment in terms of, are the patients still safe to go through CAR-T at all, just in general. But then within that, we look at our practice, even though we intend to take everybody to outpatient, on average, less than 10% of these patients may not be doing as well. They may need hospital level care, but we still think CAR-T is the best treatment for them at that time. So for those patients, we may choose to start the treatment inpatient and get them outpatient as soon as they're physically able. But the other 90% of the patient, we don't necessarily say, well, just because they have more bulky tumors, or their labs are certain value, or they're getting this product and not that CAR-T product, that we would manage inpatient. For those patients who otherwise are doing well, living their life in the outpatient setting, we would go through the treatment and the monitoring outpatient.
So I know you sort of hinted at this already a minute ago regarding not having any specific criteria about this treatment can be given outpatient or that treatment can be given outpatient. But are there some general rules that you follow as to which ones are more likely to be able to be given and successfully patients kept as an outpatient versus others? Like, do you stratify at all in any way?
Well, I can share what we do, and I'll share that in talking with many colleagues across the country. And again, this gets to institutional infrastructure setup, right, for outpatient. There are certainly centers that are saying, well, because I know how long it might take for me to get a hospital bed available for a patient, or, just going through the emergency room evaluation admission process. And certain CAR-T products on average are associated with a earlier onset of that first sign of fever, a constellation, which can lead to a constellation of symptom that we call cytokine release syndrome, which currently very commonly are still managed, mostly inpatient. So for some treatment centers, they may decide, well, if within 1 to 2 days after infusion, the patient might get a fever, and in my, practice, I need to manage that inpatient. Does it make sense to keep them out? I'll need to admit them right away. Because of my infrastructure setup, maybe I'll just keep them inpatient, manage them through that first fever, and then get them outpatient. So that's, what works for their setup. For us, what we do is we recognize that that may be a risk, but we've done some studies to recognize that there are some clinical characteristics, certain labs, certain situations that can give us some prediction on which patients are more likely to need to be admitted earlier and which patients are more likely to be able to stay outpatient longer before they get fever. And so we are not automatically admitting anybody. We are choosing to monitor them outpatient. And our goal is first is to use those predictive tools to really help guide us in terms of planning, right, for hospital bed capacity planning for patients. And the other aspect is where we keep advancing what we're doing outpatient. So we have started with early management for first sign of fever in the outpatient setting as well, and using some of the clinical markers to guide us in terms of these patients did well with outpatient initial management of fever, their fever went away, we can continue to keep them outpatient. They don't have to come in and sleep in a hospital bed. But these patients, we gave them the initial drug, we expect them the fever to go away, but they're still having some symptoms, let's admit them for inpatient care. And so I think, this is the $1,000,000 question everybody wants to know, right? Are there certain drugs that are bad? And by extension, are there certain signs that I can rely on to say, this is the right time to admit patients? Or if I know the right time, I can really plan my, healthcare resources better. I can help my patient plan, their needs. And so I think we're all learning in the field that there can be tools, especially with artificial intelligence, machine learning, how we can incorporate all of these clinical data, laboratory data, all these evolving information to really help us be smarter in how we manage outpatient care.
So we'll probably touch upon a few of your pearls in a minute when we ask about how you actually operationalize this. But so the question that obviously I'm sure a lot of people come to you and ask, how do we start going about doing this? So what do you tell them? Like, what do they need to have in place before they can even think about doing this?
Absolutely. For the treatment center, we think about how to most efficiently have a nimble uh, ability to see these patients outpatient, because this time frame that we're talking about, after the patient has received their CAR T cells, where they might get fever, they might get some neurologic symptoms. And this is also in a setting where they also receive some chemotherapy in preparation of the CAR T infusion. So their blood counts are going to drop because of that. So these patients are also at risk for infection. So just because they have a fever, we cannot assume that just from cytokine release syndrome from CAR T. We also need to be appropriately evaluating, preventing, or managing for signs of infection. So there's still a lot of evaluation that happens. And so how nimble is that clinic to be able to see patients on short notice, whether it's within a day, within hours, and then again, as I mentioned, have the ability to escalate to inpatient. So for us, what we chose, and again, this can vary across treatment centers, it's just what seems to be the best way to provide that care, right? For us, our outpatient facility is physically, it's an outpatient clinic. It's physically located in the lobby level of our hospital. And that's mainly because in Rochester, we have 2 hospitals that serves the entire practice. And the emergency room is in the other hospital. That's not where primarily our cancer patients receive their care. And so for us, we say, well, 99.9% of the time, these side effects that might pop up, we know are related to the treatment we gave. We know how to manage. We can safely manage. We can escalate to inpatient admission or even to ICU if we need to in a very rapid fashion. So we don't need to have the patient go to the emergency room and go through the evaluation there down the street and be transported back to our hospital. So we set up that clinic on the lobby level of our hospital. It's staffed by physicians, APPs, and nurse the APPs and nurse rotate between that outpatient clinic and the inpatient service. So 3, 4 days a week, they might be doing the clinic. And then the next week when they come back, they might be doing the inpatient service. So in the course of 1 month that the patient's getting treatment and being followed, they really get to know the same group of nurses and AP. There's that continuity. When that clinic closes in the evening, they give sign out to that overnight nurse team, APP team in the hospital. And so 24/7, the patients are instructed, they just call one number. They call this one number, that is this outpatient clinic. But if it's not daytime where the clinic is open, that number rolls over essentially to the inpatient team. And the inpatient team is aware of this patient. That's not the first time they heard from the patient. It's on their census list. They know this patient is, at what time point is that patient in the treatment? Is that patient at risk, for certain things? They already have that awareness and that familiarity. So there can be a rapid admission if needed overnight for those events. And the physician, of course, is covering both inpatient and that clinic service. So that's how we chose to set it up in terms of being able to be nimble, to see patients as needed, and also to have that continuity from the patient perspective. They're not just seeing entirely separate teams who may not be as familiar to their care.
So obviously you answered this partly as to where the immunotherapy program is located at your center. So I guess different centers have had different models, and some have 24/7 access to a clinic. In your case, do you after hours then refer patients if they need to be evaluated to the emergency room, or do they end up is there a bed that is always ready for a patient they require admission? How does that work?
Yeah, that is a extremely relevant and practical question. And I'll just also start by saying the other aspects, again, depending on where the treatment center is located in the country, that's really important to consider is what are the housing availabilities, are there affordable housing that's available? Because these patients, if they're away from home, they're needing to stay for, around a month's time. So how easy is it for the patient to get, to that outpatient or hospital facility? For our program, as I mentioned, in Rochester, we choose to bypass the emergency room system just because we have 2 hospitals. It didn't seem to make sense for us to send patient to emergency room when we have all the setup to do the evaluation and manage the patients. But we do have processes set up with the emergency room so that if in the rare events, and we would direct a patient if there's certain things that we feel it's faster to be evaluated in the emergency room. The emergency room is aware this is a CAR T patient. This is not a patient that can wait 5 hours in the waiting room to be seen. They need to see the patients right away, evaluate, and they need to also be in touch with us to discuss the management. I will say these are very site-specific things because even for Mayo Clinic Mayo Clinic Arizona and Mayo Clinic Florida, for example, where their hospital and emergency room are all embedded right within the same hospital, their patients are evaluated through the emergency room, and they have a process for the emergency room and how to do the admission. For
So
us here in Rochester, sorry, just the last question that you had was, what happens, how do we make sure there's a bed available and so on? 'Cause that is definitely, and I feel even more acute post-COVID pandemic, an issue that many institutions are still dealing with, right? There's been a shift of the work staff and limitation of the capacity. And the nice thing about CAR T treatment is at least you do know ahead of time the patients that have gone through collection, that, there is X number of patients that within a month or 2 months, they might be coming back for treatment. And the product patients are given. So, on average, at any given time, how many patients might be at risk for needing escalated inpatient care. And so we have calendaring tools that are keeping ICU inpatient always aware of, number at risk. It's not for certain these patients need to come in, but number of patients at risk. It does help the nursing supervisors plan because we only have so many nursing units where we know we have trained staff, right, accredited by the REMS program, IEC program, who knows how to monitor these patients. So we have to prioritize getting our CAR T patients into those units for care. And so keeping these different teams aware of potential volumes does help them plan, where they say, well, this patient, even though they are a cancer patient, they're getting chemotherapy with us, for example, but they don't have to stay on this unit. So if there's, X number of potential patient at risk, we can have this flex bed available and knowing that these other patients we can plan. So that's how we've been managing our census.
So at Rochester, during what hours is this dedicated clinic that you say is on the ground floor open for? Like, what are the operating hours?
What are they operate? Well, it's 7 days a week, but it is only in the daytime. So it is not 24 hours. And we basically stay open until the last patient is done with the monitoring and so on.
So it's usually late in the evening?
I wish at this time. So we had planned to stay later into the evening. Currently, because of staffing issues with nursing, and we actually just fortunately recently, hired our APP to attrition, but because of some staffing issues, it's more in the afternoon rather than into the late evening. There's no fixed end hour. It's pretty much when the patient is done, but it's more in the afternoon. But again, we have that flexibility where we know if patient just needs some observation period and not admission, that we have that flex hospital bed and, part of the hospital where they can still be observed, but not fully admitted.
So those patients that are getting outpatient CAR T, do they come in daily, check in at the outpatient clinic? Do they stay there the whole day, or they just are evaluated and sent home? How do you do that?
Right. Our goal is never to have patients have to stay in that outpatient unit for the whole day, because that really defeats the purpose of being outpatient. And so really, if patient needs so many, let's say, infusions, transfusions, whatever, monitoring for that many hours, that's probably really an inpatient patient, right? So our goal is really let them enjoy life a little bit if they can
Sure.
during the daytime. And so patients are seeing certainly every day during the chemotherapy days. They do get check-ins in between the 2 rest days before the cell infusion, just to make sure there isn't some symptoms, at patient education for management. And of course, the day of the infusion. Now, after infusion, there is REMS requirements per FDA in terms of the monitoring for the patient. So often this is 7 days or up to 11, 14-day window, depending on the product. And so currently we're seeing these patients essentially every day. But in reality, what we also have incorporated in our system is remote monitoring, where patients are wearing a patch that essentially is doing continuous assessment, heart rate, heart rhythm, blood pressure, so on. And also they're given a smart tablet where we're pushing out periodic assessment of some basic symptoms and neurologic assessment. And this remote monitoring system is integrated through a call center to our clinical team and to the electronic medical record system. So even when they're not in clinic, we are being alerted if something were to happen that what we predefined as potential signs or symptoms of concern. And we also have, since last year, essentially a home health visit team that on our instruction, our clinical team can go out and visit them at home. And so what we have done, for example, typically that first 1 to 2 week window, we're watching for that first sign of fever. That's going to be the most common first onset of symptoms. And as I mentioned, we started managing some of these outpatient a subset of patients will need to be admitted to escalate the management. After that, the second half of the month, oftentimes, most of these patients do not have a recurrent cytokine release syndrome. They may still need to be watched for infection. They need to be supported for blood count recovery. But a lot of this is about regaining their appetite, regaining their strength, trying to feel more normal again. And so in that time window, we've also piloted having more home health visits and only have them come in to see us in the clinic when they need some type of treatment that needs to be given in the clinic. Because when we look at the number of clinic visits, we found that only half the time we're giving them something, like a blood product transfusion. The other half of time we're just doing, reassuring them, are they taking the right medications? Are they managing their symptoms, right? So these are things we can do with home health visits. We can push out through telehealth visits. And so that part of the care where they're not coming into the clinic now unless they really need some intervention for us to give in the clinic has gone very well in the second half, where patients, they still feel connected to us because they have that remote monitoring system, and the home health visit team was working very well with us, and the patient feel like they can still kind of get to enjoy the town a little bit and so on. So now we want to pilot, can we do that in the earlier phase as well, so we can even be more efficient in how we utilize those clinic visits and still have the patients feel connected to the clinical team.
On an average, I know it will vary by product. What proportion of your patients who start out outpatient end up requiring some period of time in the hospital, though you wanted to treat them as an outpatient throughout?
Yeah, and I'm sorry, I can't give you an overall number off the top of my head. I know we presented this at ASH
Sure.
in December of last year. There are some variation a little bit across product, but I would say, we used to have probably closer to at least 3/4 of our patients who still need at some point during the month, inpatient care. And that number is probably getting down closer to half the patients. And so we're not necessarily completely removing the need for hospital care. And I think that's where the field in how we can manage and how we can advance these CAR-T product and their side effect profile needs to also advance along in our monitoring capability to say how much more can we do outpatient and potentially at even centers that are so specialized in tertiary level care. So sorry, I don't have the number off the top of my
No,
head,
that's perfectly fine.
but the numbers are definitely, we do see a trend decrease with these advanced tools and updates to our practices.
And then again, this may be a number you may not have, but how many within that critical 72-hour period that you want to try to keep them outpatient, do you end up admitting a proportion of those patients as well?
This is it definitely an area of evolving practice for us. I will say, even at the start of the FDA-approved CAR-T program, we were still seeing 1/3 of the patients, and now 40, closer to half of the patients are probably not admitted within the first 72-hour window. And so I think the more that we can do outpatient with initial management will continue to be pushing that number. Currently, we certainly don't necessarily say because you're such high risk, we'll just automatically admit you. We will try to do the initial management outpatient as long as it's safe. Now, certain factor, obviously, we cannot control for patients with higher disease burden who are coming a little bit more frail, right, with treatment. They're going to have more side effects with that cytokine release syndrome. And so the criteria we said is what's safe. If there's signs that their blood pressure is a little bit more sensitive, they're just not eating, drinking as well outpatient. Let's get them inpatient. Let's see if we can get them feeling a little bit better before we send them out. But the more that we can understand how to intervene earlier, right, reduce the likelihood to have more severe symptoms, the more we can manage outpatient.
I think you've addressed some of this issue already, so I won't belabor it. It's a team approach. You have the inpatient, you have the outpatient team, you have the ICU involved. So all of them come together to make this possible at your now. the way you run the outpatient center. You touched upon it. Just a couple of questions, more granular about policies and procedures. If a patient does spike a temperature at home, do you tell them to take some steroids, or do you just tell them to come in for evaluation? Are you using more prophylactic strategies like tocilizumab or other drugs for these outpatients? How are you approaching that?
Absolutely. This is a question that is really getting to a evolving field of practice, right? I'm sure if you talk to me in the next 3 to 6 months, that might also change again. So as you know, um, this system that I've been talking about with the outpatient management, we're using both for patient receiving CAR T and bispecific antibody. Uh, Bispecific antibody, not all of them, but many of them approved by FDA, particularly for hematologic malignancy, are coming with a REMS program as well. And they're given initially with what's called step-up dosing. So you give a very small dose and then bigger dose until the full dose, with the idea that if patients were to have these cytokine release syndrome, these reactions, you can control it better, with the medication. So during that window, which can be on average, let's say two weeks, it varies a little bit by product, the patients are monitored and managed through the same outpatient system. However, how you manage cytokine release syndrome, it's quite different. There is many of the bispecific do not have a REMS specification. You must give toci first, and then you give steroid. It's pretty open. And even on a clinical trial, it can be investigators' call. And so for bispecifics, what we have found, at least of the bispecific to date, that are FDA approved, that we're prescribing for our patients, for hematologic malignancy, I'll comment, the one for melanoma is a little bit different profile. But for the heme malignancy, what we found with our monitoring system is when we're seeing that fever, because of the remote monitoring, we're catching the fever at first onset. And many of these patients do well with dexamethasone, which is a dexamethasone pill. And we used to have them come in, take it so we can watch them closer, make sure they're doing well, and send them out in this outpatient setting. And then we realized, well, it's a pill, and they can take that at home. We're keeping a close eye on them. So currently, our initial plans for these patients is they're given the prescription for the dexamethasone, they fill it, they have it on hand, but they don't take it unless we instruct them to. They're educated on the criteria. So when they have the fever, our team calls them and make sure that they don't have other signs or symptoms that, are more concerning for them being sicker and they need to come inpatient. And then we tell them to take the dexamethasone. Our team does call them back within an hour to make sure they're doing well with that. And if it seems like they are improving, they stay home. If it seems like they're still having persistent fever, they're not feeling well, they have other symptoms, then they come in. That's when we give the tocilizumab in the outpatient clinic. If they respond to that, they stay outpatient. If they don't, they get admitted for care. So only a very small subset of our patients receiving bispecific really need inpatient level care. Now with CAR T, there's much more clear specification of the management, and tocilizumab is the common across all CAR T product first line. That is by REMS, criteria. We actually explored if there's ways we can give tocilizumab at home, but there's lots of logistical nuances. So I think that needs to be studied in a trial setting. So we're not able to give tocilizumab at home per se, but we do have the patients coming into our outpatient to get the tocilizumab. But I think, that is an area of interest because we know the tocilizumab actually can be given, potentially even sub-Q, but the kinetics of the uptake and how it works in this acute setting is very different. So more to be explored. Now, finally, I'll touch on with Axicell or Axicaptogen. Yescarta is a brand name that's known for patients with lymphoma. It has been studied in a clinical trial where if you give dexamethasone on the day of the infusion for 2 days after, that seems to reduce the overall risk for patients getting very severe cytokine release syndrome and neurologic symptoms, and maybe reducing the overall need for cumulative total dose of steroids given, so some of the risk associated, right, with immune suppression. It's not being formally studied with any of the other CAR T, but certainly for Yescarta, the FDA has updated the package insert to say this could be an intervention that could be given. Tocilizumab has been studied, no clear role for benefit to give it in a prophylactic setting for CAR T. Anakinra currently is being studied, so we don't have final data to say what dose, how, could it be helpful, but that's something that might come potentially, right, in the future. So currently for some of our patients, we feel who's at higher risk for cytokine release syndrome and so on, or even some of the neurologic symptoms, we will give that prophylactic dexamethasone with Axicel, the Yescarta, for the approved management. But it doesn't completely remove the risk. Some of these patients may still get fever. They may still need, subsequent management. But that is something that we are doing for our patients.
And lastly, before we wrap up, you've already mentioned that you're pioneers in using sensor technology. Certain centers also have, a video consult with a patient in the evening before they go to bed. Do you combine the two, or you're so now happy with the sensors that you think that you're able to do so, and only if the patient calls do you need to really speak to them?
And again, I really want to emphasize there's no right or wrong way. I think it's needs to be, I can say how we're doing it at Mayo, and I think practice, however they set this up, is something in discussion with the patient, right? The patient caregiver are comfortable with the plan, and the practice are confident in how they're monitoring the patient. For us in Mayo Rochester, we choose not to automatically call all patients who are being monitored outpatient, let's say during evening hours, because we do have confidence with this remote monitoring technology, and that's a huge piece of remote monitoring. And how is that information being integrated into the electronic medical records, or just medical record in general, right? And how are any potential alert being assessed, and how is that information communicated, triaged, and used by the clinical team? That's key. So for us, because we do know there is this continuous monitoring, there's these planned time points where these assessments are integrated with the clinical team. And at any time patients don't feel well, they can also trigger an ad hoc assessment of their symptoms or something. And the patient's always told they can always call, right? Good old phone call still works. They don't have to just completely rely on that system. But we do know that system comes in. We have predefined, these are normal range for heart rate. These are normal range for temperature. These are normal range for blood pressure. When it's outside this range, if it's outside by only a little bit, that's a routine alert. If it's outside by a lot, that's an emergent alert, right? So even the alert, there's granularity. It comes into our clinical team, so our nurse knows this one, I have 10, 15 minutes to call the patient, but that one I need to call right away, and why is the patient still at home not calling us, what's happening? So we are comfortable with that plan to say, if the patient's not doing well, even if the patient's not calling us, the system would be generating that alert. So we will be contacting the patient. So we chose to reserve that bandwidth for whether it's a phone call or televisit. We chose to reserve that for when an alert is truly generated. Now, there's nothing wrong with programs if they go, if I want to do timed assessment, I think that's perfectly fine. It's how they choose to set that up. The other question that I think is also interesting, sorry, do I still have a minute? That may come up, is people
Please, go ahead.
ask all the time, because I explain, what are we monitoring for and how we set up alert system, and people always say, well, isn't fever the first sign of symptom? And do I need to monitor for all of these things, like what's happening with all of these data? And And I do agree when we look at our data, of course, the first sign of overt symptom in how we currently manage patient is when they hit the fever, right? So I think for sure, at the minimum, if you're going to do anything at all outpatient, you need that temperature measurement. But what we're interested in finding out, and again, this is where we have the data, it's an evolving area of research and practice innovation, practice advancement, is what we're seeing right now is before the patient hit that fever, if we look back 6 hours, 12 hours, 24 hours, 48 hours, we can start to see some signals, not that it's abnormal, but some patterns of change. And so what we're hoping is that we may be able to get types of alerts that helps programs to say, well, the patient's not having fever yet, but the patient had a 70% likelihood they'll have a fever in 4 hours. And some centers may say this information is going to be useful for me, right? Because then maybe I'll be planning a phone call at that time, or I'll be planning to have bed availability or a clinic visit. Or we may have way to say that's the right time to give that prophylactic dose and not just automatically for everybody, up front. So with information comes knowledge, and then we can, potentially be actionable things in the future.
Well, thank you very much for sharing your procedures. As I said, Mayo Clinic has led the way, and though a lot of other centers are venturing into it, I think you're at the pioneering end of the technology, and I think we hope that the learnings that you have from all the research you're doing in this area will help us all develop our own programs in the future.
No, absolutely. And I love talking with different, colleagues in different centers about this, because I do believe there isn't necessarily one right way to do it, right? But there is what are useful information? How can we all use information to adapt to, our health systems and to be able to provide care for our patients? So thank you very much for this opportunity to share what we're
Oh, no,
doing.
thank you very much for taking the time. I really appreciate it. Thank you.
Thank you. Have a great day.